Good evening all, welcome to this new session. We will try to see some interesting Git spotters and we will try to see some companion cases for the complete study. So this was the first set. Here you can see there is significant dilatation of the transverse colon. Here also you can see there is significant dilatation of the transverse colon measuring approximately greater than 6 centimeters, which is referred as toxic megacolon, which is commonly seen in ulcerative colitis. And also this is, you can see there is increase in the widening of the presacral space due to excessive fatty deposition in the perirectal soft tissues. So widened presacral space is also pathognomonic for ulcerative colitis. So typically in the sagittal sections in barium studies, we have to measure at the anterior to S3 S4 vertebral levels. We have to measure the presacral space. If it is greater than 15 mm, it is considered abnormal and it is commonly seen in ulcerative colitis. Here also you can see there are multiple button shaped ulcers. Here you can see there are button shaped ulcers noted within the mucosa, and there is also mucosal irregularity in double contrast barium enema. This was also a case of ulcerative colitis. And at last here you can see there is a long segment involvement of the colon which is narrowed. Loss of hostrations is seen, and also there is mucosal irregularity mimicking lead pipe appearance. So this is lead pipe colon in case of ulcerative colitis. So these are all the different imaging findings which can be seen in toxic megacolon ulcerative colitis. And also this is 3D virtual colonoscopy showing lead pipe appearance. Here you can see this is the lead pipe appearance. Here also this is the lead pipe colon. So these are all the different imaging findings you can see in ulcerative colitis. Next case. Here you can see this is typical fat halo sign. There is excessive deposition of the fat in the submucosal region. So typically showing the fat halo sign which is seen in Crohn's disease. Here also you can see this is target sign with adjacent creeping fat appearance, creeping fat sign which is also seen in Crohn's disease. Here this is engorged vasa recta in the mesentery which mimics the comb. So this is known as nothing but comb sign in Crohn's disease. So remember, fat halo sign, target sign, creeping fat sign and comb sign in Crohn's disease. Next, here also you can see this is a child presented with constipation. You can see there is dilated bowel loop and also filled with massive fecal matter. So this is known as massive fecal loading. So this appearance, whenever you see this type of appearance, definitely suspect massive fecal loading and rule out history of chronic constipation. Here also this other child who presented with abdominal pain, abdominal distension and constipation. Here you can see there are marked dilatation of the bowel and there is no gas in the rectum. So they definitely suspect whenever there is marked dilatation of the wall of the bowel with no gas in the rectum in a child, definitely suspect Hirschsprung's disease. Here this is also an adult where you can see the colon is significantly dilated, filled with fecal matter, and also there is diffuse mucosal thickening, mucosal irregularity, and sometimes you can also see mucosal fat stranding and adjacent fat stranding. So whenever there is colonic dilatation with fecal impaction, mucosal thickening and even mucosal fat stranding and pericolonic fat stranding, definitely suspect stercoral colitis. And in these cases most of the times the rectum will be empty. So these are the different varied appearances of fecal colonic dilatation with fecal impaction. Next, these are two different cases. This is a child, abdominal pain, no history of recent diagnostic barium studies. So typically you can see there are multiple tiny hyperdense radiopaque material seen filling the wall of the colon. So this was case of geophagia, that is where they ingest a lot of amount of soil clay. So this can be also seen in some psychiatric patients. So definitely suspect geophagia in a child with chronic disappearance and also chronic abdominal pain, and even sometimes they suffer with constipation also. Here this is other case where this is adult abdominal pain, no history of recent diagnostic barium studies. Here this case was a chronic chronic acidity case. He was treated with bismuth subsalicylate. So this bismuth antacid injection can lead to typical appearance of hyperdense radiopaque material seen filling it in the colon and all. So these are two different type of appearance. In both the cases there is hyperdense material in the colon, but the cause is different. This is a child with geophagia pica, this is an adult with bismuth antacid injection, and in these type of cases definitely rule out previous history of diagnostic barium studies. Next, these are the 4 different cases of pancreatitis. Here you can see the pancreas is enlarged, edematous, and with adjacent fat stranding and also acute fluid collection, and there is few air foci, and there are multiple hypoenhancing areas replacing the head, body, and tail of the pancreas. So this is a case of necrotizing pancreatitis. Here you can see the pancreas is also enlarged, edematous, but there are multiple free air foci replacing the pancreas. So this was a case of emphysematous pancreatitis. Here also you can see this is a chronic pancreatitis case, and there is diffuse fatty replacement of the pancreas with few pancreatic parenchymal and even ductal calcifications. So this was a case of chronic pancreatitis with fatty replacement. Here this was a case of cystic fibrosis where the body and tail of the pancreas is completely not visualized and is nothing but replaced by fat. This is pancreatic lipomatosis in cystic fibrosis. So those 4 different type of pancreatitis cases. Here this is other case where you can see this is a hypodense area noted in the hypodense lesion noted within the liver with adjacent layered pattern or target type of appearance. So whenever you see a hypodense collection noted within the liver with central calcification, definitely suspect brucellar abscess. So solitary abscess with central calcification, so definitely suspect brucellar abscess. Here you can see there is a hypodense collection and surrounded by multiple small cluster of small hypodense areas or collections, and you can also see there is double target sign. So double target sign, you can see there is inner enhancing mucosa surrounded by edema. So inner hyper enhancing layer is edematous layer of the abscess, and the outer one is nothing but the edema adjacent to the abscess. And these are the multiple tiny abscesses adjacent to the adjacent to the lesion. These are nothing but the cluster sign. These tiny abscesses or multiple cluster of abscesses fuse coalesce to form the single large abscess. So whenever you see double target sign and cluster sign, classically in case of pyogenic abscess. Here also you can see this is a large abscess with irregular wall, and even there is internal septations, and also there is fluid debris level. So this was a case of amoebic liver abscess. And also in amoebic liver abscess you can also see changes in the colon, and also there will be adjacent perihepatic free fluid, even pleural effusions and ascites. So thank you all.